So let me now turn it over to Nina and Deepak to introduce the insurance keynote of the day.
All right, hello everyone. So Blue Cross Blue Shield of Massachusetts is one of the largest independent nonprofit plans in the country and the largest health plan in the state. Today, Andrew Dreyfus will discuss lessons and strategies from pioneering efforts to tackle healthcare costs.
Andrew is the president and CEO of Blue Cross and Blue Shield of Massachusetts. In the past, he served as the executive vice president of healthcare services. He also served on the Commonwealth of Massachusetts Special Commission on the Healthcare Payment System. Please join us in welcoming Andrew. Great.
Good afternoon. I know you've had a long day and a fascinating day, and I kind of looked at all your speakers. Am I a little loud? And what I want to do first is congratulate Andy Sussman, because he's been a colleague of mine for years. And also, you'll see a chair coming out. I'm going to walk around a little bit, but I've injured my foot. And so I may, after a few minutes, kind of wander over to the chair and just sit, because I'm not supposed to be standing on it for too long. I was in a boot. I've gotten out of my boot, but now I'm still have to be gentle with it. So I want to tell you a Massachusetts-specific story that has national implications. I want to talk to you about how a group of leaders and a group of organizations have developed a new way of thinking about payment in Massachusetts, which has led to changes in the delivery system and ultimately changes, at least influencing some changes across the country. And I see other people in the audience who were part of this story. That's you over there, right, John? And so I'll be interested. I'm going to try to actually get through this fairly quickly, because I'd love to have a little dialogue. But I want to start by just telling you this coverage story, because it is still a remarkable story that in 2004 and 2005, we started a conversation in Massachusetts that we had postponed for years about how we get coverage to everyone in the state. And we passed a law in 2006. It was implemented in part by John and others in 2007. And we got to what I would consider full insurance. These are actually Western European levels of coverage fairly quickly, and we've been able to keep it despite some downturns in the economy at a very low level. And it's really quite an accomplishment. But perhaps equally as important, we saw indicators of health also improve. So for years, people had speculated that there was a tie between insurance and health, but it had never been fully explained. And so after coverage got expanded in Massachusetts, you can see people reported having better health, more likely to have a personal doctor, and most important of all, as you see at the end, we actually saw an increase in mortality. So insurance saves lives. We now have kind of overwhelming evidence for that. This law became the model for the Affordable Care Act. There was a time there where it was kind of a little bit of a political football, and some people didn't want to associate the Affordable Care Act with Massachusetts. Some people did. But suffice it to say that the basic building blocks of our plan here in Massachusetts became the building blocks for the national law. But while that law tackled the problem of coverage, it very explicitly did not tackle the issue of affordability or costs. And so the framers, if you will, of the Massachusetts law actually had a conversation and a debate about should we include cost control mechanisms in the law. And the answer was no, and the reason the answer was no is because we had tried in Massachusetts, and other states in the nation had tried over decades to pass a law that would both solve the coverage problem and solve the cost problem. And every time we did that, the coverage issue got held hostage to cost. And as a consequence, no law was ever passed. So we said, we're going to delay that problem. But it's a big problem to delay. So this is a chart probably many of you have seen before. It's just a way of saying that the United States remains the most expensive place to get health care, and Massachusetts remains the most expensive place within the United States to get health care. And the combination of that led to a great sense of urgency to do something about costs, and we were feeling it. as the largest health plan in the state, we were feeling a lot of pressure from the governor, from regulators, from legislators, and most importantly from our own customers. Healthcare premiums were growing at double digits, and it was a real problem. So, and I should just say that at that time, the growth in spending on healthcare in state government increased. Let me orient you to the slide. On the left-hand side of the slide is the growth between 2001 and 2014 health spending in government. And so it grew by $5.4 billion. And this is the drop by almost the same amount in spending in a whole bunch of other areas, including public health, mental health, education, human services. And those who study public health as well as business know that it's actually health itself rather than health care that determines the outcome of healthcare, especially for low-income people. So while we were cutting what might be considered the social determinants of health, we were shifting a lot of money into the healthcare system. And so not, from an investment perspective, not the best investment. So while this debate was going on and while the kind of fire was growing within Massachusetts to do something about healthcare costs, back at Blue Cross, as you heard, the largest plan in the state, we started to struggle with this issue. What can we do as a health plan to solve this cost problem? And we took the path through quality. So at the same time, those of you who have been around healthcare know that in the late 1990s, early 2000s, a movement began focusing on the quality and safety of care. There were a series of reports from the Institute of Medicine that said 100,000 people were dying every year due to errors in the healthcare system. Our system wasn't of high quality. And so we sat back and said, how can we, as a health plan, improve quality and promote affordability? And we did what every good health plan would do in a situation like that. We hired a consultant. And we asked a consultant to go scour the country and find a payment model that could help us improve quality and cost, because we knew as a payer that the most powerful lever we had to solve the cost and quality problem was the way we paid for care. And we were hoping that there would be a plan out there that we could adapt or just implement to Massachusetts. So we got, of course, like a 200-page report with, 40-slide deck, and it basically said there is no such program. In fact, there was more chronicle of all the failures. The failure of capitation, which was a mode of payment in the 90s, and especially in California, a little bit here and in the Northeast, pay-for-performance programs that weren't really changing anything. So we decided we had to do it ourselves. So we sent a group of experts at our plan, physicians, nurses, reimbursement experts, measurement scientists, and others, into what we called the cave. And we called the cave so much so that when they came out, we gave them those miner hats, with the flashlights on it. And we said, you invent a system that rewards quality and promotes cost. And what they developed was something called the alternative quality contract. And if we knew it would have been such a big hit, we never would have called it a name like that. We would, in the Blue Cross system, everything's blue. So we would have called it Blue Sky or Blue Innovation or Blue Breakthrough. In fact, like our employees, when they take courses, it's on the blue campus, so everything's blue. But we called it the alternative quality contract, and by the time we sent it to our marketing department to get a better name, it had already stuck. The acronym was known, and AQC is now known around the country. If I go to California or Florida or Michigan, and they know I work for Blue Cross Blue Shield of Massachusetts, they say, oh, the AQC. So what was this plan? Well, the first part of it was it used a global budget, meaning that we would pay physicians and hospitals, rather than per service, we would pay them a fixed amount for each Blue Cross member that the physicians were taking care of. And unlike old capitation models, which had some similarities, we would adjust it for the health of the population, and we would share risk with the physician practices. Secondly, we developed a list of about 64 quality standards that had been tested and vetted nationally, certified by a group called the National Quality Forum, that would measure the process of care, the outcomes of care, and patient experience of care. And then finally, rather than having this adversarial relationship between plan and physician and hospital, where every year, every few years, we sit down at a negotiating table and have a negotiation about price, we would mutually commit to each other's success in a sustained partnership over 5 years. And with that model, we went to a few pioneering organizations in Massachusetts. We said, will you engage with us? Will you partner with us in this model? And initially, 2 or 3 did. And quickly, by 2014, 88% of the primary care physicians in Massachusetts and almost 90% of the specialists are now operating under this model. And if you see there was a big jump between 2011 and 2012, you might wonder, well, what happened? Well, what happened was a couple things, but the first thing was that I decided to send a letter to all the physicians and hospitals in Massachusetts saying, you know, we have some early success here. We've been doing this now with a couple thousand physicians, and we have some early results that are very promising. We want this to be the primary way we pay for care. And so the old system, the so-called fee-for-service system, where we pay for every visit, every admission, every procedure, and we're not paying for health and outcomes, is going to be in our past. And instead, we're going to pay based on quality and results. And if you want it, it's optional. But if you want to stay in the fee-for-service system, we're really going to constrain your ability to get increases. Now, I thought it was a very thoughtful, kind, carefully worded letter. Well, the next day on the front page of the Boston Globe was a headline above the fold, Blue Cross CEO, cut costs or else. It got referred to as the or else letter, and the Massachusetts Medical Society, the leading physician group, called me the next day, and they summoned me to appear before their executive committee to shake their finger at me and say, you're going to ruin the medical care system in Massachusetts. And by the end of the session, I explained to them that it was actually their physicians, these early physicians working the model, who told us they were providing better care for their members. They were still earning not just a salary, but a margin, and that this was the system they wanted to aspire to. And so suddenly, we got much higher rates of adoption. So this is currently a kind of a look at who's in it. And rather than, don't look at the names, but what you can see here, there are large academic medical centers like the Beth Israel or the Brigham or the Leahy Clinic. There are small community hospitals. There are independent practices that aren't affiliated with hospitals. There's some in rural areas, some in urban areas. There's some in low-income areas. And I'll just mention the low income for a second, because some people thought, well, this will work for your standard, middle-class suburban practice, but could it work in an urban community where the patients face, difficult language, cultural, economic, transportation problems? And I'll tell you that some of the practices working in the lowest socioeconomic areas are actually performing the best. And so this is a model that we think can work anywhere. So it's now become one of the biggest payment reform initiatives in the country, but it's certainly the most closely studied. So from the start, we took a little bit of a risk. We said we invited in a group of researchers who were funded separately from our company, led by a health economist at Harvard Medical School called Mike Chernew, and said, we want you to evaluate this every year. Every year they evaluated, and every year they submitted their results to a peer-reviewed journal, Health Affairs, New England Journal of Medicine, and this was the most recent analysis, which looked at 4 years of data and saw that by the 4th year, costs were down 10%. 10%. That's a huge savings. And that, well, actually, I'm going to go back and clarify that, because I have some probably economists in the room. The growth in healthcare spending was down 10%. So it wasn't that absolute costs fell, but the level of growth fell by 10%. Equally as important, quality was up. So just to look at this slide, so that kind of brown bar represents the national average for a set of measures, so-called HEDIS scores, which measure a set of preventive measures in adult chronic care. And you can see that the national work was flat. But in Massachusetts, the physicians operating under this system went up year over year. And similarly with outcomes, a lot of people say, well, these programs, they only measure the process of care. No, we're measuring outcomes, and you can see the outcomes went up so high. What this represents is that in some cases, 90%, 9 out of 10, for example, of diabetic patients in the physician practices operating under this payment model were getting the right level of care, and were having their blood glucose level under control. So those were really remarkable results that even the researchers were surprised at. Now, it wasn't just enough to pay them differently. We had to support the physicians differently. And this is not a chart you're intended to look at the details, but we provide our physician groups with daily, weekly, monthly, quarterly, and annual reports about their performance. Sometimes it's as simple as, did you know that your patient was admitted to the hospital last night through the emergency department? Because for physicians who aren't on an interoperable electronic medical records, they didn't know that. To much more sophisticated analyses of costs, utilization, quality, financial performance, and results. And one of the things we looked at very carefully was something called practice pattern variation analysis. So we look at a set of high cost, high variation procedures and diagnoses to show the physicians how they're performing. So let me orient you to this slide. Every dot on this chart represents a gastroenterologist in Massachusetts. And what this displays is how frequently they perform an upper endoscopy for a patient who has a reflux syndrome. And you can see that some physicians all the way at the top, though there are 4 dots, do it every single time. Some gastroenterologists never perform it, and there's everything in between. Those arrows point to 5 gastroenterologists who practice together, who see the same kind of patients, who perform very differently, and had no idea until we showed them these results that they practice differently. The line in the middle shows you the average of around 55%. There is not a right rate that we know or that the Gastroenterology Society, either in Massachusetts or nationally, knows. But when faced with this kind of data, they look at their practices differently. And this same kind of chart and the same kind of analysis we can show you for procedure after procedure. So if I showed you low back pain and how many times a physician ordered an MRI for a common low back pain within the first month of diagnosis, you'd see the same variation. And when we present physicians with this kind of information and a lot of others, they change their practice. There are sometimes they actually should be performing more tests, but more often than not, fewer tests. We also provide them with opportunities to share their own success and results together. So we bring them together in collaborative groups. This one you see on the left, for those of you who don't know, and that's Atul Gawande, talking to the group about end-of-life care. How can the groups think differently about that part of care where we often in healthcare there's a fear that we're going to get less when we want more. But at the end of life, we often get more and want less. And this was talking about what techniques can these practices use to counsel their patients who have serious advanced illness and other topics. So what have we seen the delivery system do? They're changing the way they practice. So some are using different staffing models. A big issue in primary care now is mental health, psychiatric health. And that system has been very fragmented. So a lot of these primary care practices are now embedding social workers in the practice. So if a patient comes in or a child comes in presenting with a mental health problem or diagnosis, rather than saying, well, here's a referral, go make an appointment, they walk down the hall and they right there have a consultation with a social worker or a psychologist. They're engaging patients in different ways. One of the physicians who practiced on this model, who led a group of physicians, like to say to me that, Andrew, it's not about the visit. In fact, we have to end the tyranny of the visit. Healthcare happens between visits. And so what are they doing to engage their patients between visits? If a nurse is sent to a home of a chronically ill elderly patient, the first 2 things they tend to do is look down to see if there are any loose rugs in the apartment and go to the medical cabinet to see what prescriptions are in there that might have a drug-to-drug interaction that the patient's not aware of, because the average chronically ill patient often has 5 diagnoses and a dozen of prescriptions. They're changing the way they think about their referral relationships. And so in the old days, if there was no incentive for the physician to think about the affordability of their care, when they sent a patient for surgery or for a diagnostic test, it didn't matter what the cost was. In fact, they rarely knew what the cost was. Now that they're on a budget, they start thinking about those referrals in different ways. So Mount Auburn Hospital has a very proud cardiology practice, but a certain percentage of their patients get referred to Mass General Hospital, where the cost of care of cardiac patients is more expensive. They start to think about that in new and different ways. And obviously, they're using technology to track their patients very differently. So this is also raising questions about what's the responsibility of the hospital or the physician, the provider, versus the plan, and some of those services that fall before. Because it used to be that providers knew exactly what they did. They took care of patients when they were ill in their offices or in the hospital. Plans knew that they were to sell products, design benefits, sell them, and manage networks. But for years, the plans also were responsible for coordinating care because the system itself was fragmented. And so now we're starting to think about how do we move some of that work back perhaps where it belongs in physician practices. This, however, is raising a question, and one I've been thinking more about, which is about integration versus fragmentation. You probably heard a lot today about how the healthcare system, which has been so fragmented, needs to integrate. And our payment model actually incents integration. So that's why you see hospitals buying hospitals buying physician practices. They want to have all the care together in one place in a seamless network for patients. On the other hand, we also have a lot of disruptive innovators, and I know you talked about disruption earlier. I would actually say that where Andy works, CVS, they are potentially as big as they are also a disruptor because they're introducing their minute clinics, and we have other disruptors, telemedicine, urgent care centers, wearable technology, and that's changing. And so we have this kind of tension right now in the healthcare system between those who are trying to integrate and those who are working towards more fragmentation. But this payment reform I think we're at the point now where we can't go back. The Obama administration announced several months ago that the CMS, which accounts for about 40% of all payments for hospitals and physicians, is changing the way they pay for care towards so-called accountable care. And we, too, are expanding our model. Our initial model that I described to you only worked for our HMO members. We've now figured out, after 2 years of a lot of research, how to apply this somewhat complex model to our PPO members, those who have freedom of choice of their plans. And so at this point, I think there is no turning back. But ultimately, this is a lot about what payers are doing and what providers are doing, but ultimately we have to solve the problem for patients. And thus far, our healthcare system for the last 50 years has been designed around the needs of health professionals and payers and to some extent purchasers, but not around the needs of patients. I think this is leading us there, but I think we still have a lot of change to come. So with that, I'll stop, and I'd love to take any questions you have.
Thank you, Andrew. So we're going to have the mics up and down the aisles again.
Yes, you want me to call on people right here?
I think there's some here.
Okay.
There's one here, Kim. There. Yep, right here. Do you want to raise your hand? Sorry, Kim.
Thank you, Mr. Dreyfus.
Yes.
So my question is, I've talked to practice managers who are very excited about the quality contracts, but when they actually get to the nitty-gritty, a lot of the metrics that they see feel very unreachable and they get put down by how hard it is to move the numbers. How do you address that and make sure it's a reach goal but not so easy or so unattainable?
Yeah, well, it's a great question, and there is certainly measurement fatigue already in the practice environment, and there's a little worry about, are we trying to teach to the test like in the education system? And you hear things about cookbook medicine and all that. And I guess my response to that usually is, first of all, I just like let the results speak for themselves, because, and I once said to our governor, our previous governor, who wanted to rapidly accelerate this when he saw the results, I said, to be honest with you, it's not going to be governors, elected officials, or health plan executives who are going to persuade physicians that this is a better way of practice. It's going to be other physicians. So that's what we've tried to do. We've also tried to learn from that. I mean, we retire measures that are not good. When we went out initially with our measure set, clinical measures, the physician said, you ought to pay more for the outcome measures than for the process measures. So we doubled the payments we made on outcome measures and lowered what we made on process measures. Practice standards are changing on a regular basis, so we have to be aware of that. Look at the debate over cholesterol levels and what the right level is. So I think if we show flexibility, in some cases what we've also done is we've allowed practices to experiment with their own measures. When it became time to sit down with Children's Hospital and we showed them the measure set, they said this works for adults but not for kids. And so we worked with them to develop a pediatric measure set, and together had the first pediatric ACO program in the country. Finally, one new thing we're doing, which I'm really excited about, is we're adding to the measure set patient-reported outcome measures. So measures of how do the patients feel about the care, how quickly are they going back to work, how's their pain being managed, and those are outcome measures. And initially, we don't know exactly how those measures are going to work, so rather than paying for a result, we're really paying for participation in those measures. So I actually feel like we're advancing the measurement field quite a bit, and I'm enthusiastic about it. But great question. Yes, over here. There are two over here.
Yeah. So.
Oh, three over here. Okay. Yes. You have the mic. So.
Yeah. So the question that I'd like to ask is that quality issue, quality of care, and outcome for the patients. You're paying the providers for the bills, the various provider system. And how do you see what you can do in terms of getting the best result besides the measurement? And what did you mean also that you're doing a care to the measurement rather than care to the outcome? If you could also combine those two questions.
Yeah, those are kind of subtle questions. I mean, I guess, I'd just start by saying that under the old system, if there was a primary care practice up the street here at the Beth Israel, and they had a group of Blue Cross members, and they were very successful in treating those members, let's say they had a chronic illness, such that they would kept them out of the hospital, we pay them less. If in fact they didn't manage those patients well and they were admitted to the hospital, we paid them more. If while they were at the hospital they contracted a preventable infection, we paid them more again. So the system just felt backwards to me. And initially with this plan, we set out a set of measures, and they cover cardiac care and diabetic care and infections in hospitals and a whole bunch of other measures that have been validated over a number of years. And if the physicians perform well on that, they're going to earn more money. One question is, well, what about oncology care? Or what about care for arthritis where you don't have measures? There, we've been well persuaded, and I think most physicians would agree with us, that in order to do well on the set of measures we have, the physicians really have to reorganize their practices. And that reorganization will benefit all their patients. In fact, another question which you didn't ask, but one could ask, is this a competitive advantage for Blue Cross? And I would say the answer is probably no, at least initially. Because when patients go into a physician's office, they're not noting are they a Blue Cross member or a Harvard Pilgrim member or a United member. They're just taking good care of that patient. And we, for quite a while, were the only plan that was paying these significant bonuses for better performance and quality. So I'm not sure I'm completely answering your question, but I have a lot of confidence, and our clinical leaders have a lot of confidence that the care our members are receiving under this plan is of higher quality than it was before. And you're starting to see that not only are we paying that way, but our our other plans, fellow plans in Massachusetts, like Harvard Pilgrim and Tufts are as well. Now that Medicare is doing it, the system's going to shift. And rather than just being concerned with the care of individual patient, they're also being concerned with the health of the population that they're caring for. Questions up here?
Yeah, Andrew, I wanted to commend
Yeah.
you and Blue Cross on the ATC. I think it's an incredible example of corporate leadership. So we had a discussion a few minutes ago in the panel upstairs
Yeah.
with payers and providers about the perceived failures of plan design evolution
Yeah.
and deductible plans. How do we personalize our products to the needs of the individuals that they make more decisions as consumers?
Yeah. So this is a great question. You know, early on in our work here, one of the hospital leaders said, you know, physicians don't want to be cops. They don't want to be saying, you can't go here, you can go here. And so there was some concern about that. And they kind of said, well, it's one thing for you to give us incentives to change our care. What are you doing to influence your own members so that they make choices that are consistent with our own recommendations? And that really falls back to us on product design, as you say, and also, as you suggest, that the main movement in product design has been to shift costs by introducing higher deductibles or higher cost shares. And I would say that plans like ours and others have been a little behind in using that new responsibility that members have to try to complement the work we're doing with physicians and hospitals. I now actually feel we're getting there. And so we have, for the last several years, put plan designs out that tier hospitals based not just on cost but also on quality and on the same quality measurement that we're doing here. And so if one of our members is under one of those plans is going to a low-cost, high-quality hospital, they may pay $100 out of pocket. If they're going to a high-cost hospital or a low-quality hospital, pay $1,000. And the difference between 100 and 1,000 starts to be really meaningful to patients, especially if it's obviously we don't do that for emergency services, but for a service. We have to do a lot more of that. And then secondly, we have to accompany that with the tools. So I'd like to be able to provide, if a patient goes to see a doctor and they have low back pain and the doctor does say, I think you need an MRI, that they could right then and there go onto their smartphone, look up and see exactly where are the 5 closest MRI centers, how much are they charging, how much is it going to cost me, and where am I in my deductible today so I know exactly what my personal liability will be if I make choice A or choice B. We will have those kind of tools in the market in 1116. They're not going to be perfect. They're not going to cover every diagnosis or service possible, but it's a start. So we do have to complement the incentives. So you can consider these kind of supply side incentives and consider the kind of patient incentives, demand side incentives. And our customers are actually, they're excited about this and they actually like to see the results and they realize that it's going to drive the total medical care down, but they're really interested in what we're doing on the demand side. So even if we didn't need to do it just for the compliment our customers are asking for us, so you'll see a lot more of that in the market. Right behind you.
One of the questions I wanted to follow up on was a comment you made that there would be practices in an urban setting with diverse patient populations who can perform very well. Yeah. I was curious if you came across any statistically significant differences. As an example, employed practices with an integrated EMR with the healthcare system, better than affiliated, worse than affiliated, on common dimensions of difference. What was significant?
Yeah. We've done some of that analysis, probably not quite at the level of specificity you ask. And it was interesting that we thought that those practices that had a pre-existing integrated, either integrated multi-specialty or integrated EMR would perform better. Not the case. I mean, one of our highest performing early groups was a group out in the western part of the state. There was a series of independent practices, onesie, twosie, threesies that had come together in coordinated way, that were doing a lot of their care coordination, in type forms and not online, and performed very well. So while I think over time, especially with larger groups, we certainly think that to do the kind of data analysis you need to do requires an EMR and other integrated systems, but it wasn't the early differentiator. And so it seemed more to be about leadership at the practice, about education of the physicians, about making some of those other changes with social workers and nurse practitioners, about thinking about home care and a whole bunch of other steps. The early opportunities for savings were really around their referral patterns, but over time it really got focused on those 5% of everyone's patients who are driving 50% of the spending, and those are mostly people with multiple chronic illnesses. So it really got to the high-performing groups were figuring out how to manage those 5% of members more successfully. Questions over here and way in back. The first part of the question with the recent change in what?
With recent changes in the guidelines, how quickly do the quality measures begin to reflect those changes?
Yeah, I mean, we try to introduce them as quickly as possible. The complicated thing is that sometimes, like on this cholesterol measure, it's not stable. It'll come down and go up. But as soon as we have a clinical consensus on a change in a quality measurement, we'll change it. And one of the, I think, advantages of a plan like ours versus, for example, a government agency like CMS is we are more agile in that respect. And again, we've retired measures, we've added measures, we've tested measures, we've added so-called developmental measures that we're not paying on, but we're just recording, and so we can do it fairly quickly. And again, we don't introduce the measure until it's been kind of certified by the National Quality Forum, which itself spends a while vetting them. Question right in front of you, yes.
Glad you actually got this slide up for this question.
Yeah.
You mentioned that health plans, large health plans particularly, have had a real hard time dealing with the patient-centric nature
Yeah.
of medicine. How do you feel about the Clovers and the Oscars that are
Yeah.
that are truly tech companies?
Yeah.
Valued over $1 billion with only 200 employees.
Yeah. Yeah, it's really extraordinary. So those who haven't followed, there's a company based in New York called Oscar, which is a kind of completely online insurance company about to enter markets in Los Angeles and Dallas. There's a group called Collective Health out in California. So there are these different models. First of all, I welcome them because I think probably more legacy companies like ours need to be challenged by young companies like that. I'm a little surprised sometimes at how highly they're valued. And there's a lot of, I was just out in San Francisco meeting with some venture funders who are looking at some of these startup companies. And we have a venture arm at our company, and we too are investing in some young companies, less in the insurance space, but more in providing some online tools. One of the ones I'm really interested in is a new company called Ovuline that's Boston-based. People of my generation, when your wife got pregnant, you bought a book called What to Expect Where You're Expecting. But my 24-year-old son, if ever he becomes a parent, he's going to want it right on his smartphone. And this is an app that provides both fertility guidance and pregnancy guidance for young couples. And so I do think a company like Oscar might accelerate our work to be more member-centric, to be more consumer-centric, and we kind of welcome the challenge. We have to do it. Take a look, at the great form called the, EOB, or Explanation of Benefits, the form that says this is not a bill. We redesigned that form 3 years ago, and we were so proud of our redesign. It made it so much simpler and so much clearer and used simple language. And as soon as we did that, it was already out of date because it was being mailed. And it was happening every time a transaction happened. Shouldn't you get that once a month, online, like your credit card bill, that's very clear to understand, and then you can actually manage? It should. And those are the kind of changes we have to make. And if we can't make them fast enough, other competitors will displace us. In back, way in back, purple tie, purple shirt.
Yeah.
When you are mentioning about
plan design and the kind of member Blue Cross interaction relationship. I'm wondering if you could comment on the fact that, often the kind of healthcare deciders for many folks are their employers, and what are some of the big challenges about aligning the interests of the employers when we're trying to get certain products or certain plan designs in front of members as well?
Yeah. Well, I mean, generally, we are well aligned because employers are purchasing care and they are hiring us as their agent to try to organize the care and organize the benefits and pay for them. It's been interesting because I think 3 or 4 years ago, there were a lot of predictions that employers would get out of the business of providing health insurance, either because there are now public exchanges to which they might be able to refer their employees, or because of the creation of so-called private exchanges, and there was a fear or a risk that health benefits might be treated like retirement benefits, and we'd have the same migration like from pension plans to 401ks that we would have on the health insurance side. And thus far, it has not materialized. And I think the reason, I mean, there's been some movement, but it's been very modest, is that employers still view the health benefit as a competitive differentiator. They want to take good care of their employees. We have a real shared alignment around wellness. And while the ROI in wellness has yet to been fully proven, employers now understand that their healthier employees will be more productive. It affects absenteeism and presenteeism. And so we are very well aligned. Some employers choose to pick different vendors for different parts of the services they provide, and that can also lead to some disintegration of care, back to are we integrated or fragmented. But I'm excited about the employers in our community. They're getting, back to the question about aligning product, they're getting much more aggressive about wanting their employees to have a different experience in the healthcare system, and for plans like ours to be able to offer them results and evidence to back that up. One last question. We have a clock ticking in back. I'm going to do it.
Okay.
Oh, do you have a mic back there? Okay, back there, sorry.
I really enjoyed your talk, and
Thank you.
my question is about the more difficult patients, and you alluded to them, the patients that have multiple diseases. Yeah. And one question I had is if a patient has, is not agreeing to do the treatment they need to have, and the doctor is recommending it, and if they don't agree to do the treatment, and then of course it's not going to work out, their cost is going to go up, and will doctors start saying, well, I'm not going to take this patient anymore? What happens to the more complicated patients who are difficult to treat?
So first of all, just without going into too much detail, that was one of the great risks or mistakes of the old capitation model, that there was potentially an incentive for physicians to avoid the sickest patients. So first of all, we removed that incentive entirely by risk or severity adjusting our payments. And in fact, what I heard from physician leaders, we want the sickest patients. Why? Because that's where the greatest opportunity for savings are. If you have a healthy patient, you're not getting as much risk-adjusted payments. There's not a lot of work you can do to improve the quality of care. But for those very ill patients who are spending so much of the 5% that generate 50% of the spending, or the 10% that are or the 1% that are generating 20% of the spending, that's where the great opportunity is. Now, your question is, what happens when those patients come in the system and they're non-adherent or non-compliant? That hasn't been a big problem. For the most part, we haven't heard complaints about that. We think that, that if a doctor said that, I think I would kind of question and say, is that practice really trying hard enough? Have they used different methods to do it? And this issue comes up around patients who have both a psychiatric and a medical diagnosis, and we've been doing some special work with them because sometimes compliance is harder in that area. Sometimes you have to think about, should the medical care be offered in the mental health setting as opposed, I talked about social workers embedded in medical practices. Well, what about nurse practitioners embedded in mental health practices? And so there's different ways to do it, and I have a lot of confidence in the ingenuity of our physicians to do it, and we haven't seen any evidence of physicians either forsaking patients or patients forsaking physicians because of this model. I'm out of time. I really appreciate your your patience, your great questions, and I congratulate you on all the good work you're doing today. Thank you very much.